Good afternoon, everybody. So I know that everybody is filled with good knowledge and good food now. And I will definitely try my best to deliver the topic in a short and in a crisp form. So I'm very proud and happy moment here. So I can't start without acknowledging this moment because most of my teachers are here, most of my colleagues are here, and I'm taking this opportunity to thank my beloved sir, Vindet sir, to give this opportunity to deliver or handle this topic to this quality crowd. Thank you, sir. So coming to the topic, impression to fit in. So that's the topic. So in that topic, I'm just covering what exactly the lab steps in a crisp form. So being a dentist or being a dental professional, I'm very proud, or we all must be very proud that we are seeing a lot of innovations within a short span of time. Within a short span of time, so we are from an era of impression compounds to dental photogrammetry, that is 4D ICAM camera system, even to make the implant positions very precise. And also, in this particular moment, I think we have to salute all the personals who are working for the betterment of dentistry all over the world. Digital or conventional? So this is one of the biggest question in our mind nowadays. We should realize that is a digital or conventional, what make us complete, or what is exactly meant by conventional or digital? I can say that digital is not a magic wand. It is not a magic wand to make the things easy. It is not a magic wand to make the things very easy and with forgetting all our basic steps. It is exactly for improving the predictability of the prosthetic outcome and making the patient's experience better. So without knowing both conventional and digital, we can't excellence in the field. So it's very important to remember that completely digital is not particularly a magic wand. So coming to the conventional protocol, basically the clinical steps includes impression making. There will be a jig trial and jaw relation. There will be a teeth setting trial, depending upon the area. If it is an aesthetic area or like aesthetic area to be restored, or it can be a full mouth case. So in that particular area, we will go for a teeth setting trial. And the visit 4 will come like there will be a prosthetic prototype, or depending upon the prosthetic selection, it can be a frame plus teeth setting trial. And in the 5th visit, it can be a ceramic body trial or a final prosthesis delivery. So coming to the lab steps, it will be like, I will combine this both, but in the lab step, it's basically it's about the preparation of model. So gingival mask pouring, and there will be a model preparation, and after that, a jig fabrication and a bite block or a special bite fabrication will be there, and the articulation of the jaw relation, and then there will be a teeth setting trial, and the abutment selection, and the milling of the selected abutment, then the fabrication of the prosthesis which is being selected, and the completion either by ceramic layering or it can be a wraparound with acrylic. So combining both this clinical and laboratory, you can say that like after impression making, this particular work is coming to a lab where the gingival mask is pouring and model preparation is done, and on that particular model, jig and bite block fabrication. And it is sent to the clinic for a jig trial and jaw relation, and it will come back to the lab for articulation, and there will be a teeth setting, and according to the jaw relation, there will be a abutment selection. And after that, the teeth set will send for a trial to evaluate the patient's profile, bite, vertical dimension, everything. And then it will come to the lab where we will design the full anatomy to produce a prosthetic prototype. And after the prosthetic prototype is being made, that trial is also done clinically. And after that, final and definitive framework, depending upon the selection of the material. It can be either metal, or it can be a zirconia, or it can be like acrylic. Anything can, the definitive processes fabrication will be done. And next is definitely the final delivery. So, including in the laboratory step, usually we have an unpacking system which is meticulous. We all know that all the components are really precious and it is valuable, and we have to make the unpacking very clear so that the recording of the enclosures will be done. And there will be a token box system is kept within the laboratory to make sure your components are placed and they are safeguarded. And after unpacking, there will be a registration process. It is basically that registering the particular work into the software of the company or the lab, where all your details has to go in. So if there is a confusion in the patient name, if there is a confusion in the doctor's name, that will unnecessarily delaying the work. I'm just adding this as a tip, because if you can fill the instructions or the form very well, that will create, that will eliminate the unnecessary delays and unnecessary calls to you. Okay, and then coming to the impression. Yesterday we heard a very good lecture from Dr. Srinath. He explained both impression techniques, implant level and abutment level well. So I'm not going much detail into that, but there are some questions which we are regularly getting to the lab. It's about, yesterday doctor said about transfer copyings. There will be, for recording the implant level impression, there are open tray transfer copyings and closed tray transfer copyings are there. But there is sometimes we receive some impression with non-engaging transfer copies. So where exactly we should have to use non-engaging transfer copies? This is one of the questions which we are getting regularly, and the answer is usually a lab recommends a engaging TC for making impression. But if you have only the non-engaging transfer copyings, the lab can only deliver you a prosthesis in a non-engaging abutment. Okay, can I repeat? That means if you have only the transfer copyings in non-engaging, the prosthesis will be delivered only in non-engaging abutments. And next is about the emergence profile. The recording of emergence profile might be, we created a very good emergence profile during the surgery and during the temporary time. So how we can record this particular emergence profile using a transfer copy? Of course, it can be with a flowable composite, and some doctors will do with light cure. Okay, or light body or putty impression, or they will use flowable composite. That means we are customizing the transfer copies emergence profile to record the same. One more thing is we are very familiar with the X-ray checking of the jig trials. So it would be good if you check the fit of the transfer copying onto the implant before the impression. If the implant is bit subgingival, or it can be subgingival, or it can be bit angulated, where you can't assess the predictability, or where you can assess the fitting of the transfer copying to the implant, this X-rays will be very good. And you know that even with scan bodies, we recommend X-ray. If it is digital too, but we should ensure the fit of this both transferring mechanism or transferring components to the implant. It should be a very important part. Next is what happened. I'm just talking the practical scenarios, what is happening. So sometimes what happened is the doctor is taking a good impression, he checked everything, he filled everything, and it's sent to the lab. And might be the clinical staff will forget to send the screw, or they forgot to send the analogs. This also can happen. So this will again delay the work, and you will get unnecessary calls Of course, this was not there, that was not there. So it will make unnecessary delays. Coming to the impression. So in laboratory, so we are getting a lot of, in a laboratory, maybe in a day about 200, 300 impressions can be there. Most of them are very good, but sometimes we can see impressions like this. Here, everybody can appreciate. So if you are not checking the fit of the transfer copying or scan body, for example, for a transfer copying, what happened, the light body or your impression materials can flow into this on the top of the transfer copying, and finally it's end up with an ill-fitting processes. Hope you can appreciate that in this particular transfer copying, we can see a material light body is flown on the top of this. Maybe double impressioning also is happened. We almost focusing on the implants. So the adjacent tissues also has to be recorded. This is a small video where we can appreciate these transfer copyings are being moving within the impression. So if the transfer copyings is moving within the impression, what will be the result? The technician can pour in any different angle. So this will end up in a ill-fitting processes. Sometimes this also can be expected. So this is an open tray impression is being taken with a closed tray transfer copy. So with a closed tray transfer copying, an open tray impression is being made and there is no retention of the transfer copying within the impression. So sometimes this also can happen. So next is about in closed tray impressions also, double impressioning can see. You can see here, there are two records of the transfer copying, two impressions of the transfer copying is come. So here the technician can pour like this or like this. So both will end up in an ill-fitting processes. And sometimes, yes, this is one of the other reason for unnecessary calls from the lab. Might be what happened is in the impression you can see the diameter which is used is a narrow platform, but the analog which is being sent is of a regular platform. So this will also make the technician in confusion, and they had to think or they had to check with the doctor which is the actual diameter in the patient mouth. And in in the next impression, you can see that the adjacent area is not recorded well. So after pouring this impression, we will get a model like that. There is literally no space between the adjacent teeth and the transfer copy. So recording the adjacent teeth contact is very important to establish a broad and tight or point contact according to your preference. And here also, in snappy abutment techniques, closed tray, pickup impression, if as like the TCs are not fitting correct, the impression materials can flow into the snappy cap. So after getting a good impression or seeing the impression and connecting or checking all the components, then it will proceed to the gingival mask pouring. So this is actually the gingival masks are an important part of the model itself, and it is actually to be returned to the lab. So silicone material which is poured around the implant analogs to get the gingiva area around the implants. And after that, the gyroform setting will done, and then the model preparation is being done. Okay, so once the model is ready, then you will definitely get a call from the lab. Should we send the jig trial or not? Or shall we send a jig trial or something? So is it necessary to check a jig trial? How important the jig trial is? Rather digital or conventional. So there is a talk like that, if you are going digitally, there is no need of jig. And if you are going conventionally, jig is mandatory. But actually it is not like that. Jig trial is a step which whether we are conforming the patient mouth, the position of the implant in the patient mouth and the position of the analog in the model are same. So after conforming this only, it is better to start the work so that we don't have to start from the scratch again if your processes will end up in an ill-fitting something. So we would like to recommend jig trial, like not for a single unit or something which we are not recommending, but above something involving three implants or two implants, jig trial would be good. And there are two types of jigs, especially what we are delivering. There will be joint, there will be a splinted one, and there will be a splitted one. So we know that exactly the parallelism or angulation that all plays right from the selection of impression method, and of course making the jig also, the angulation between the implants are the deciding factor which kind of jig has to be prepared. So if your implants are in good parallelism or in less divergence, we can go for a splinted jig. And if the angulation is much more, we can go for splitted type. Yes. Then after fabrication of the jig trial, it will get into the laboratory and get into the clinic. So in the clinic, we must have to check the jig trial with the IOPA. So in this IOPA, you can see that sometimes this is not seating well, or there can be a gap between this. It's about the failure of jig trial. So in these situations, we can see sometimes we have to cut the jig and we have to go for a no impression. So is only radiographs matter? No, we should see clinically how it is presented. So in this particular step, you can see there is a gap between the natural teeth. So the jig is connected to the adjacent natural teeth where you can see a gap. So in this radiograph, definitely the transfer copying is sitting on the implant. But clinically, it is not. So this is a wrong jig. In splitter type also, in this particular case, you can appreciate a gap. So this is also a wrong jig where it is an interpreting that the distance between this implant and this implant is not similar that of to the model. So jig trial is checking both with the X-ray and clinically both are important. And here it's just one slide to show you the error in digital impression also. If we fail to record the scan surface or the scan identification flag area or flat area, or it is another layer is being formed with the tongue space or any additional tissue layer, this can also end up in ill-fitting processes. So in this kind of cases, we would strongly recommend the jig trial. So some tips like that. Sometimes we felt like that some doctors will interchange the implant system. Might be it is compatible with each other, but definitely you will get a call which is the actual implant system in the patient mouth. So compatibility is of course it's an acceptable thing. So if you are mentioning the actual implant system in the instruction slip or something, we can use the same abutment for making the processes. So always stay within the implant system, and it is regarding the selection of impression material, impression method. So that is again depending upon the angulation, open tray impression, and then it's regarding sending the proper components. So using diameters of same transfer copying and analogs are appreciated. And also checking the fit with IOPA, and then regarding the stabilization of transfer copyings with pattern resin or composite, and things which we have to see the recording of the soft tissue and adjacent tissue recording, and it's about the sending of the right components. So this is about the impression part. And next, After the jig trial or along with the jig trial, you will receive a bite registration record. So normally it will be like if it is a distal extension case or like an anterior case or something, the bite registration material will be less. And for full mouth case, it will be something which we call a special bite or twin bite will be there. So the first plate will be connected to either two implants of the two quadrants, and the second plate, which you can easily perform the jaw relation. So the first plate will be fixed to the implant, and on the second plate you can do the jaw relation. So for this, along with the impression, if you are sending two non-engaging abutments, it can further avoid the delay. It can avoid further delay. So using these two non-engaging abutments, we can fabricate the bite registration record and send to you. Articulation is the next step. So after the jig trial and bite registration, we are getting the work in the lab, and we will do the articulation. And after articulation, there will be a teeth setting and the putty indexing of the same. So why it is being done? Actually, by doing this teeth setting, we are predicting the site, what will be the future site for the prosthesis, or how the adjacent tooth or how the prosthesis will come. Okay, and we will make an index of this. This is exactly to done for selecting the abutment. So after doing this teeth setting only, or after doing the jaw relation, we can select the abutment. So before going into the details of abutment selection, I'm sure that we all are very familiar with these terms like there are stock abutments, customized abutment, multi-unit abutment, tie bases, hybrid abutment, castable abutment, ball abutment, angulated screw channel abutments. There are a lot of abutments, but basically we can classify it like into stock abutments and customized abutment. All these abutments are being selected according to the prosthetic need of the case. Okay, and also regarding the way we choose, either it can be a digital or it can be a prosthetic, conventional type. And just a part of refreshment, we all know that the parts of abutment, there is engaging and non-engaging abutments depending upon the change in the connecting part, and there is a margin and there is a prosthetic part which is holding the prosthesis. So these are the factors. These are the factors which are affecting your abutment selection. The first and foremost factor is the divergence or the angulation. And second one is the preferred mode of retention. We know that everybody is preferring screw retained rather than cement retained. And next is about the collar height or the gingival height. And then is regarding the clearance or the crown height space, the room for the restoration. And then is the emergence profile, what we created according to the relation to the soft tissue. So these are the basic factors which are affecting the abutment selection. So coming to the first point, that is angulation or divergence, or in terms of parallelism between the implants. So this is actually serves as the bread and butter of implant prosthodontics, where we have to see whether your prosthesis will be screw retained or cement retained. So if the implants are parallel enough, we can go for a screw retained prosthesis unless and until it is affecting the aesthetic region. So for screw retained crown and for all the cement retained crown and bridge, we will use engaging abutments. And for all screw retained bridges, we are using non-engaging abutments. So depending upon the angulation of implant, the path of insertion and the long axis of the implant determines the mode of retention. And at the end of the day, sometimes if the implants are not parallel, and everybody will cry for a screw retained prosthesis. For in a screw retained prosthesis, what happens is your connecting part, the abutment is already incorporated to the prosthesis. This is actually a screw retained prosthesis, where this is a cement retained prosthesis where the abutments are being placed first, and on the top of the abutment, the prosthesis being cemented on. So this angulation between, so in this particular picture, in this kind of divergence, I know this is a bit exaggerated, but see, to show this, this kind of divergence, we couldn't expect any prosthesis to get into place with the connecting part. So in this case, definitely we have to change the area, that means the support, the abutment. We can change the abutment angulation to receive the prosthesis. We cannot change the long axis of the implant to receive a prosthesis. So in this kind of situation, the multi-unit abutments came into play, where you can change the angulation up to 30-35 degree to receive a screw-retained prosthesis. So after the selection of abutment will be prepared. This abutment will be prepared to receive the what exactly the prosthesis. So another important question what we regularly encountered is, what is abutment customization? So all the stock abutments are the ready-made abutment, ready-made titanium abutments, or ankulated abutments. So if it is not possible with that particular abutment, stock abutment, if your prosthesis cannot be fabricated, then we will go for customizing the abutment. So what exactly the customization? There are two ways for customization. One is with the castable abutment, that is a conventional method. In this conventional method, what will we do is actually there are two kinds of abutments. One is with the connecting part and other with fully castable abutments. So either with both of this, we can customize this particular, the wax is being added, and we are making the abutment into a particular shape which we required. And it is casted and it is polished. And it's being used as abutment. And there is digital customization. It is nothing but we will take a pre-milled blank. In this pre-milled blank, the connection is already milled according to the implant system is being used. And after that, we will design this particular prosthetic part according to the margin. And it will be designed and it will be milled out. So this particular modality in Dentcare, it is called Dentcare milled abutment. This is exactly how we are customizing the abutment in a digital way. So only two methods, one is casting and this is customization. And another thing is also angulated screw channel. Even still we require something in cases, particularly in anterior cases where the aesthetic zone is being interrupted. We can use this angulated screw channel method where we can correct the angulation of the implant. And we can avoid coming the screw access hole in the labial aspect by 20-25 degree. So this is also being introduced into different implant system, but Nobel Biocare, they are the pioneer to do that. So now a lot of implant systems have the same feature. And coming to the different implant prosthetic solutions, there will be implant-supported crown and bridge. There is implant-supported hybrid denture. There are mallow-concept bridge, and there are implant-supported or implant-retained over dentures. So when to select these kind of materials, or when to select this, which abutment, or which kind of processes? Before going to that, I just will rapidly go through which all other materials are available. So for implant crown and bridge, we have metal-free options. There is Dentcare Zirconia, PEEK, and there is IPS, HIPC, and in metal, there is DMLS, both in titanium and COCR, and there is conventional casting technique, and there is facing and temporary. Temporary options, either there are three methods now, regular, heat cure, and there will be printed and there will be millable. So for especially in implant, usually everyone prefer for millable PMMA. Then the next option is hybrid denture. So hybrid denture is nothing than its name itself is, it is fixed, it's a fixed denture, but it has the properties of acrylic. the lightweight. So it is fixed and it is lightweight, where the material, wraparound material is acrylic. So the material options for the frame inside the hybrid denture are PEEK, Bio-HPP, titanium, and COCR. So we know that still the lightweight materials are being in innovations. The best material right now available is PEEK and Bio-HPP. And then coming to the metal aspect, it will be titanium, and then to the COCR. Then the material options for the wraparound, there are different acrylic options. Yeah, there is Plus, Impact, Inject Pro, and BPS. So these are the material, different types of acrylic, which is aesthetic indifference and strength indifference, which you can choose to do the hybrid denture. And other is Mallow Concept Bridge. For Mallow Concept Bridge, we also have different material options: titanium milled option, titanium DMLS option, and COCR and Bio-HPP options to do the frame. And on the top of the we can go for any kind of crowns. Either it can be zirconia or nova, or it can be composite, millable one, or anything. So this is about the Mallow concept. This is how it is being designed. And coming to the implant overdentures, there will be a fixed framework, and on the top of that, with which various mode of attachments are there, and on the top of which we have different kind of overdentures. So the fixed frame can be fabricated in different materials. It can be titanium milled or COCR casting, and the framework for the overdenture. That means the frame inside the overdenture. So that will be also PEEK milled, titanium DMLS, COCR DMLS, and COCR casting. And different kinds of attachments are also there. There are bar and clip attachment, ball and socket attachment, ball attachment, and telescopic attachments are the different mode of attachments. The selection of these attachments is purely based upon the space available in the laboratory's perspective. And it is different, the distance between the implants, where you have a space for an attachment, where you have the height for an attachment. So in this way, you can select the attachments. And how we can select these materials for your case. So how we can select is basically the space, the room available. That means crown height space or the vertical dimension. Then the other factor is occlusal plane, and the third factor is regarding the angulation or the site of the implant. So basically, coming to the vertical dimension, it will be, we know that, you all know that there is FP1, FP2, and FP3 prosthesis. So in this concept, if your work is fall in an FP3 classification, we can imagine that if we go for a metal ceramic work in an FP3 situation, the metal, the weight of the metal and the weight of the ceramic will be more. So in that particular cases, we will suggest the other material options. Like it can be a titanium, which is layered with light pure composites, or we can go for hybrid denture, or still, if the height is more, we can go for removable overdentures, or we can go for Mallow concept works. So in Mallow concept works, the frame will be in lightweight material, and still we can maintain the aesthetics with zirconia crowns or ceramic layering. So this is how the vertical dimension or the space or the height of interarch distance matters in selection of material. Yeah, in this particular case, the site is very important. Here we have to restore, it's an aesthetics on, everybody know that. But for the second quadrant, the height for the abutment, even for the abutment, it is very less. So in this scenario, might be we have to go for a conventional or a direct casting. We cannot go for a zirconia. But in anterior, of course, the implant is placed, might be the patient is highly convinced with the zirconia work. But in this situation, we can't go for a zirconia in second quadrant. Sometimes it ends up like this. Completely no occlusal plane. So the room for restoration, so how much length we can increase? We couldn't increase the length of the abutment more than this. So in this restoration, there will be no benefit to the patient. Sorry. Sometimes it will be like this. No need of implant at all. So implant is being placed, but the site is very different. Angulation is very different. So even digital or conventional, nothing changes. Even I take a scanner, impression with a scanner, a scan body. Even I take a conventional method, result is the same. Another case. So, next case. I know I don't want to speak anything, showing these pictures. Okay. And here also we can see all the 4 implants is being placed in a very buccal angulation. The first picture, it's on outwards. And here, in every picture is self-explanatory. So for prosthetic planning is very, very essential to get a good prosthetic outcome for a successful plan. Successful implant placement should be like a prosthetic-driven implant placement.
We skip to the good part.
You've arrived at your destination.
Okay, so taking the words of Brennemark, with implants, with all the knowledge you acquire from this all about implant, and with my small lecture, we can say that no one should die with their teeth sitting in a glass of water. Thank you.